then we now go to the next talk, and that is diet and exercise interactions for the treatment of Pompe disease, and that is given by Mark Tarnopolsky. And Mark is very well known in the field. We know each other already for a very long time. And you're from Canada, Ontario, and I'm looking forward to hear your lecture. You're a pediatrician in metabolic diseases.
I'm actually an adult neurologist, but I'm in a pediatric department. Anyhow, thank you so much for the introduction, and thanks so much for the AMDA for the invitation, and I had a wonderful time last night. It was my first rodeo. Some people say it's not my first rodeo, but that actually was. It was lovely. So as mentioned, I'm talking about diet and exercise interactions. I could talk for 3 hours on this, so I'm going to be really quick to highlight just the key points. These are my disclosures, the most important of which is the fact that I am the CEO and founder of Exerkine Corporation, and some of the products that I'm talking about today we actually have commercialized for the use in obesity and aging. So is exercise beneficial for Pompe disease? These are some of the summary points from a review article that we published a few years ago. First of all, there's two main types of exercise, endurance and resistance. Of course, you know endurance is longer duration, lower intensity, tends to increase mitochondrial mass. And of course, by increasing cardiovascular health and cardiovascular risk lowering, there's benefits to endurance exercise training. And as you'll see later on, obesity is a big factor in our neuromuscular disease patients. Many of them are not moving as much as one would expect because of their neurolocomotor disability, and you'll see that even though it may not appear that they're obese, it is a big issue in our patient population, so-called obesity with low muscle mass. One of the things that I'm going to focus on today is the activation of autophagy and lowering reactive oxygen species. And there is a potential that when we exercise, we may improve capillarization. We know that happens to able-bodied individuals after a long period of time. And could that improve the delivery to muscle? We heard from Mark Roberts earlier that only about 1% of the ERT actually gets to muscle. So improved capillarization could be another benefit from endurance exercise. And of course, with resistance exercise, it's obvious in younger individuals, older individuals, even those up to age 92, we can get an increase in muscle strength. So does that occur? I'll show you in a minute. It does with Pompe disease and other neuromuscular disorders, and that, of course, could be a benefit. The other important aspect is increasing bone mineral density. People have an increased risk of falls with neuromuscular disorders, and the bones can become fragile because of the lack of activity, and it can become a vicious cycle. So improving bone mineral density, which happens with resistance exercise but not endurance, could be a benefit. And also increasing fat-free mass. Just an increase in muscle mass can increase the rate of disappearance of glucose and so lower the risk of type 2 diabetes, which is quite prevalent in our population that have low skeletal muscle mass. And we're still trying to see whether there's a possibility that we could increase mannose-6-phosphate receptors. We know that beta-2 agonists, good work coming out of Dwight Coberle's lab in Duke, has shown that beta-2 agonists can increase mannose-6-phosphate receptors. And we know that there's beta-2 agonist activation with exercise. So it's an interesting possibility. So does it actually work? This is one of the first studies that actually prospectively looked at combined endurance and resistance exercise in Pompe patients. So these were 5 late-onset Pompe patients who were already on ERT. They did 5 months of supervised combined resistance and endurance exercise. So some weight training and some cycloergometry type activity. And what they found at the end of it, depending on which muscle they were looking at, there was between a 15 and 50% increase in strength, which is quite impressive. But more impressive, I think, and to put it into context, the 6-minute walk test, which is a metric which many people use to determine the efficacy of ERT and other interventions, increased by 45 meters. Keep in mind that the original LOTS trial, the improvement on ERT was 31 meters. Now, it's not to say that this is better than the other, but this was additive to the LOTS trial benefit that we saw with Myozyme. And I think that's another important take-home point, is that it's not going to be one single therapy that's going to help our patients. It's going to be a combination of many therapies, I think, that's going to be important, and hopefully my talk will get to that point. So we looked at some of the mechanisms in Nina Rabin's knockout mouse model. These were the GA knockout mice available from Jackson Lab, compared them to littermate controls. And what we did was a standard exercise training protocol. This is endurance exercise, so we were running them on a treadmill at 16 meters per minute, which is a fairly intense activity. We gave them Myozyme, which we infused before exercise. And our outcome metrics were rotorod, which is a combination of balance and endurance, grip strength, which we just heard about from the lovely talk that we just heard minutes ago. We looked at the mitochondria, we looked at glycogen, we looked at autophagy, which we just heard about as well. And some of the work by Nina Rabin and others have clearly shown that autophagic impairment is significantly deleterious to muscle function. So improving autophagy, improving that flux is of benefit. And of course, with my interest in my main area being mitochondrial disease, we looked at mitochondrial function. So what were the summary? Bottom line is that with the endurance exercise training, of course, we improved the endurance exercise time on a rotorod. We lowered oxidative stress, and some of you may be familiar with the paper that came out showing that N-acetylcysteine and idabenone, by lowering oxidative stress in both cells and in a Pompe mouse model, was beneficial in the Pompe model. We also showed improvements in mitochondrial capacity, and people might think, well, how does exercise lower oxidative stress? When we exercise, we should get an increase in ROS. Well, you do acutely, but eventually our body upregulates antioxidant enzymes, and that brings down the basal oxidative stress. And we showed clearly that important antioxidants like manganese sod and copper zinc superoxide dismutase went up in response to exercise. And we've shown that in Duchenne dystrophy models, we've shown it with aging, et cetera. But importantly, we showed that there was an increase in autophagy. So the question then for us, given that we have a lot of experience coming up with multi-ingredient nutritional supplements for mitochondrial disease, was could we apply some of these to the mouse model? So the reason why we're interested in this is, many of you may be familiar, I'm a mitochondrial disease specialist, and mitochondrial dysfunction is really important because when mitochondria don't work, we get oxidative stress, we get a reduction in protein synthesis, we get an increase in inflammation, and we get what's called stem cell exhaustion, which is very important ultimately because these are really the stem cells for our muscle. But importantly, all of these factors lead to impaired autophagy. So we've spent decades looking at ways that we can improve mitochondrial function in our patients with mitochondrial disease and in the mitochondrial disease that everyone in this room has, which is aging. Sorry, but every one of you is going to die from mitochondrial dysfunction. You all have this disease. So targeting this is important. And if we look at all of the disorders that we see in the clinic, from Pompe disease to FSH dystrophy to sporadic inclusion body myopathy, myotonic dystrophy, and what everyone in this room has, you all have mitochondrial dysfunction, especially those of us who are over 60, and it's going to result in this cascade of events. But we do feel that these are targetable by exercise and by multi-ingredient supplementation. So this was one of our approaches with 1,3-butanediol. I won't give you a background, and thank you kindly for that introduction, as to why we chose ketone as one of the components of a multi-ingredient supplement. So we wondered, could we enhance the benefits of ERT by further activating autophagy and by using a multi-ingredient supplement we use in our mitochondrial disease patients to improve mitochondrial function? And could this combination be beneficial and enhance ERT? So these were our groups, and this is published if people want to get into the weeds of the nitty-gritty. Again, we used Nina Rabin's mouse model. We provided them with ERT, and of course, we always have a control mouse to compare to. We used 1,3-butanediol, which is split to beta-hydroxybutyrate and acetoacetate. I don't have in here the research that we did, but we also used just some of the salts. So we did use a beta-hydroxybutyrate salt, which is available commercially in the US as Keto Force, and it didn't do anything. We used the standard ketogenic diet, which is, I think, why our ketogenic diet didn't work. This is the typical 93% fat, and I think the reason is that we don't have high protein. So again, this is not that we have differing data. There's a very good reason for why our ketogenic diet, as you'll see, I stole the thunder, didn't work. And then we used a antioxidant with beetroot extract, creatine, CoQ10, lipoic acid, and vitamin E, which, as you know, is my sort of core for my mitochondrial patients. And then we added some citrulline to see if we could further activate autophagy, and beta-hydroxymethylbutyrate, which is a metabolite of leucine, which lowers CK and decreases protein degradation. And then we threw them all together in a multi-ingredient supplement. So what did we see? So if you look on grip strength, for example, you can see the second group in the MUT-CON is the mutant control. So that's what happens in our mice. I'll just show you here that they lose strength over time. And what you can see is to the right there, you can see the mutant ERT mito is the mito group here. This is the butanediol, and this is everything together. Bottom line is that with the butanediol and the mitochondrial enhancers, we saw a preservation of grip strength so that they weren't losing strength over time. And with the butanediol and the mitochondrial enhancer here on the right, the rotorod function was actually enhanced. Now, what about glycogen? So too many studies take a muscle, they homogenize it, extract it into water, and they measure total glycogen. What we care about is the intralysosomal glycogen. And so what we did is we used some of the work that came out of Sanofi Genzyme years ago, where we used semi-thin toluidine blue stain sections so that we could quantify the intralysosomal glycogen. And what we found was there was really no effect between the different groups. So ERT lowered intralysosomal glycogen, which has been shown many times before, and we did not further enhance that. So was there any other benefit to muscle? What explained why the animals were doing better? So these are just several markers. I won't go into the mRNA versus the protein, but if I draw your attention to the graph on the right, this is a marker of autophagy. So lowering levels are important. And what you can see here is that they're very high, as has been shown multiple times before with the Pompe mouse model, but they are lowered with the therapies. And the biggest lowering, which is really the theme of this talk, is with that multi-ingredient supplement, which is on your far right here. And so we also looked under the electron microscope to look at autophagic block. So this took a lot of time, actually measuring the areas of impaired autophagy. So everything you can see here circled in red is autophagic block. And when we quantify this through multiple sections, you can see that the butandiol and the butanediol with the mitochondrial enhancer was our lowest autophagic block. So we were removing some of that autophagic impairment. And then I spoke to Nina, who was involved in this research, which I'll acknowledge at the end, and she said you should use galectin-3 as a marker of autophagic impairment. And so we got the antibody, and sure enough, you can see galectin-3 on the left was actually lower. And importantly, at the end of this, and also with the subsequent paper that came out showing that antioxidants were of some benefit, we also found that we could lower reactive oxygen species. By design, of course, we're improving mitochondrial function, and we had a variety of antioxidants in the mixture, so that was important. But as we've heard earlier, well, who cares if it doesn't relate to function? But what we show here clearly is that if we have lower autophagic block, we have increase in grip strength. And if we have lower oxidative stress, we have an improvement in grip strength. And that's depicted here, showing a relationship between the biochemical metrics and functional outcomes. So I'm going to finish my talk with something that has become really clear to us in the clinic. And it came in sharp focus to me when one of our patients with SMA came in who was obese and had bariatric surgery. And we do quantitative strength testing in our lab, and his quadriceps strength went down by 40% after his bariatric surgery. He said he felt a little bit better, but if you review the literature with bariatric surgery, low-calorie diets, or Ozempic, you lose a huge amount of muscle. In 1 year, the average loss of muscle on Ozempic is 8 pounds. On tirzepatide, the new one that's coming out by Lilly, is 10 pounds. Do you think that's beneficial for our patients? Probably not. So one of the things that we've been doing is we look at body composition, because the BMI is garbage, and we have a paper coming out on that. We need to look at actual muscle mass, we need to look at bone mass, and we need to look at fat mass. And when we do this is a very small fraction of a huge paper that we have coming out. Essentially what we have is body fat here on the bottom and body mass index. So most people use body mass index as your marker of obesity. Over 30 is considered to be obese by BMI. However, the more relevant metric is your actual percent body fat. So about 40 years ago, there was a rough correlation between BMI and body fat, so people just conveniently use it, but it doesn't really reflect body fat. And that's very apparent if we look at our variety of patients. So I won't get into the acronyms here, but these are myotonic dystrophy patients, Duchenne dystrophy, and of course, Pompe disease in purple. And so what you see is that although every one of these lines here are considered to be normal weight, but you can see by proper metrics, they're all obese. So this really reflects sarcopenic obesity. You do a BMI, everything's fine. And some of our patients, we had a patient with mitochondrial disease, her BMI was 17, her body fat was 50. So if you saw her and what the nutritionists say, BMI of 17, fat, 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 eat more fat. It's the worst thing for her because she had severe sarcopenic obesity. So what can we do about this? When we give Ozempic or we staple their stomach, you're going to lose a huge amount of muscle. So we spent a lot of time, almost 5 years ago, trying to come up with a way that we could actually lose body fat but preserve muscle. No easy feat. So we came up after multiple millions of dollars and many experiments with one strategy that actually was able to do this. So what we used is a high-fat fed mouse model, and obviously the mouse is very obese, and they got fatty liver disease. And then after we fattened them up, we put them on a variety of different interventions. One of the interventions is exercise. So we do endurance exercise, which is really the gold standard. And importantly, it's always something that we have to include, because if exercise is so good, what if we had a supplement that negated the benefits? And that's not an ephemeral question, because people have shown that various antioxidants can blunt the signaling and completely eliminate any benefits of exercise. And since I'm so interested in exercise and we know it's so good for our patients, I would not want to be part of a company that promoted something that blunted the benefits. So we always have that in there. So what we had was first a weight loss supplement that we came up with. Originally there were 5 ingredients, multiple iterations. We came down to the essential 3: green tea extract, green coffee bean, and forskolin, which activates cyclic AMP, and our core mitochondrial enhancer based on our mitochondrial work, which is the alpha-lipoic acid, CoQ10, vitamin E. But some very nice work coming out of Sweden shows that beetroot is the only substrates through the nitrates that actually improves the efficiency per unit mitochondria. All of our stuff increases mitochondrial mass, but that improves efficiency, so we added that. And this is all published. There's multiple iterations of this that you can see. So the bottom line is, in red, those are animals continuing to eat the high-fat diet. Of course, they're going to get more obese. In mauve, down here, you can see that's exercise. Of course, it's beneficial. There were about 10 lines in here for different combinations, but the sort of green line here is actually what we ended up calling TRIM7, which are those essential ingredients. But importantly, I was thinking we're going to have to abandon this whole project because we have antioxidants there, and that paper came out showing that vitamin E and vitamin C blunted the benefits, but we actually doubled the benefits of exercise. So that's the green line at the bottom. So at least that was encouraging, that anyone that we had who was exercising should still derive benefit. So then what we wanted to do is that will help us to lose body fat, but what about increasing muscle? We've spent decades trying to increase muscle mass in older adults for sarcopenia. My first postdoc, Stu Phillips, who's arguably the top person in the world in protein metabolism now, has published a paper that came out here in 2017 showing that a combination of whey, calcium, vitamin D, creatine monohydrate, and fish oil, as compared to an isoenergetic and isonitrogenous placebo, increased strength, lean body mass, and even improved cognition. And these were apparent even before they started exercising, but of course it's synergized exercise, lowered triglycerides and inflammation. So we actually bought the patent, and then I used my humanized milk idea, which is instead of taking a whey and casein ratio that cows came up with, so cows are 20% whey, 80% casein, human milk is 60% whey and 40% casein. And so what we did is we flipped around that ratio, lowered the protein dose to make it more palatable and to be more compliant with people's regular intake. Calcium comes in with the casein, which is important because high doses of calcium on their own can cause or promote atherogenesis. And everything was isonitrogenous to a collagen placebo. Again, we replicated their data, which was encouraging, but we had something that was more commercially viable with a lower dose of protein based on our humanized milk ratio. So what about human clinical trials with the TRIM7 that we talked about? So we did a study in 60 overweight and obese men and women aged 20 to 55, and we had 3 months of the TRIM7 versus placebo. Our primary endpoint was weight loss because that's what the FDA and Health Canada want. However, we're much more interested in muscle and fat because the Ozempic folks, and try and find the data, it's buried deep in the supplementary files. They don't want you to know that you're losing muscle, and they say that body composition is better, but find the supplementary. Muscle mass is massively lost. So of course we measured that as one of our important outcomes with DEXA scanning, which I'd encourage all of you to do. Like our data in the animal model, we showed a significant improvement in fatty liver disease. ALT and AST went down about 26 to 28%. But importantly, there was no loss of muscle whatsoever with this combination. The fat loss is the same as Ozempic at 3 months. So if you take out the muscle loss that they lose, it's exactly the same as what people get with Ozempic, but unlike Ozempic, there's no muscle loss. So bottom line is we are doing a study now in Pompe patients and in myotonic dystrophy patients. This is my last slide. It's a phase 2 randomized controlled trial. We've already put our first 2 controls through, and we're hoping perhaps some people here may be interested in doing this. We're hoping to get 26 late onset Pompe disease patients, equal men and women between the ages of 21 and 65. We're going to do endurance and resistance exercise because our multiple studies have clearly shown one is not better than the other. The 2 are the optimal sort of program. And then they're going to be on a supplement, that muscle enhancer, the body fat loss agent, the TRIM7, and omega-3s, which synergize the muscle 5. And of course, we're going to do all sorts of functional outcomes that are relevant, and you've seen these all in clinical trials before. And most importantly, we're going to be doing body composition with this. We also have a study going on now in young healthy people in an independent university looking at this combination, but we think this is probably going to be the optimal for our patients who have significant loss of muscle mass, and many of them are sarcopenically obese. And of course, a variety of different molecular and biochemical measures. So just to summarize and thank everyone, again, thanks to the AMDA for partially sponsoring our study, and to the Lint family in particular, who is providing quite a bit of funding for this study and transportation for our patients. Thanks.
Thank you very much, Mark, for this excellent